Bismillahirrahmanirrahim. Assalamu alaikum, ladies and gentlemen. Thank you very much for inviting me here to this forum. It's the first time I'm coming to Bangladesh, and it's indeed a pleasure. So these are my disclosures. The systemic therapy in gynecological cancers, we are familiar with chemotherapy, but we have moved on. And we've moved on to more targeted therapy consisting of anti-angiogenesis, PARP inhibitors, and immunotherapy, hormonal therapy. So one size does not fit all. And there are different strategies that we use for different patients, as has been illustrated very well with Dr. Bhagya Lakshmi, who has made my job very easy by covering a lot of things that I'm supposed to do. So there are paradigm shifts in the management of ovarian cancers. And the standard of therapy in 1996, when we were very excited, was the results of this adjuvant chemotherapy trial in ovarian cancer with paclitaxel and cisplatin, which became the standard of care in 1996 for ovarian cancers were stage 3 and 4. And then carboplatin replaced cisplatin, and since then, paclitaxel and carboplatin has been the backbone of the treatment. It has not been replaced in the past 28 years. So despite of having a very good response, even in the advanced stage setting, as you're familiar, that about 70 to 80% of the patients are sensitive to platinum-based therapy. They will have a beautiful response, but we know that the responses are short-lived, and the duration of these response over a period of time will lessen. What can we do in order to improve this time? What can we do to maintain the responses and to maintain this kind of, so that patients have delayed recurrences or prevent recurrences? When we talk about the evolution of maintenance therapy, back in the early 2000s, we were giving chemotherapy after the completion of the adjuvant therapy as a maintenance therapy for 12 months to these patients. So we were giving monthly paclitaxel for 1 year. Then this was associated with a lot of neurotoxicity with a very little marginal improvement in the progression-free survival. And what was it doing to us? It was basically making us feel secure that we are doing something for the patient. Then came the era of anti-angiogenesis, and we know bevacizumab. Bevacizumab is the oldest anti-angiogenesis agent. It is a VEGF inhibitor, and we have two pivotal trials here, the GOG-0218 and the ICON-7 trial, which have demonstrated that the addition of bevacizumab in different doses and different duration of time in the 218 and the ICON-7 improves the progression-free survival. The GOG trial demonstrated that the best time to give the bevacizumab to these patients is when they have aggressive disease, when they have a lot of bulky disease and ascites, and to start it in the neoadjuvant setting and to continue beyond it. Now, for the longest time, we were thinking, what is the best time to give, what is the best duration of anti-angiogenesis? Should we give it for 15 months? Should we give it for 12 months? Should we give it for 22 months? And this issue was laid to rest by this trial, which looked at the optimal duration of bevacizumab in the frontline setting, where patients who had completed 15 months of Bev were continued for another 15 months, and they were randomized into these two arms. And what do you see? You see overlapping of the graphs. You see there is no difference. So now the standard of care is bevacizumab at 7.5 or 15 milligrams per kg for 15 months. So now to a chemotherapy backbone, you've added one targeted therapy. How about we look more into the tumor and see if there's any other targets that we can exploit? As you're well aware that the frequency of genetic mutations in ovarian cancers is quite high. About 1/3 of the patients, about 1/4 of the patients to a little over that will have a BRCA1 mutation, which is either a germline mutation or a somatic mutation. And then there are other mutations that we see, which are homologous repair deficiency mutations, which are also responsible for treatment, which are also sensitive to treatment with PARP inhibitors. So who should get the genetic testing done? Well, everybody should get genetic testing done, because that's going to influence your decision in incorporating a PARP inhibitor therapy to this patient, and you can change the outcome. You can lengthen the time of duration of their response. So according to all these societies, the NCCN, SGO, ESCO, and ESMO, they all recommend doing genetic testing even in the elderly. Why? because you can confer synthetic lethality to these patients by giving them PARP inhibitors. So what happens is you have a DNA. If you look at the normal cells, you have a DNA which has double-stranded and single-stranded breaks. The double-stranded breaks are repaired by BRCA and the single by the PARP. So if you have a homologous repair deficient gene, which is either a BRCA gene or a PALB2 gene or a RAD51 gene or so forth and so on, you will have breakdown in the double-stranded DNA, but this is going to be repaired by the PARP. Now, if you inhibit the PARP in a patient who has a BRCA mutation, then you're basically killing, you are destroying the DNA and you're causing a synthetic lethality. Now, so patients who have BRCA mutations and patients who have HRD deficiency are candidates for PARP inhibitors. So let's walk in the park and see what can we do for maintenance and beyond. Everybody is familiar with the SOLO trial. The first approval of this trial was back in 2018 in the December, so this is almost 6 years ago. And what do we have now? We have 7 years of follow-up. So these are stage 3 and stage 4 patients who, after completing their neoadjuvant, the debulking surgery and adjuvant therapy, regardless of the extent of the residual disease they had, were randomized to olaparib for 2 years versus placebo. And what do you see? That the patients they completed their treatment at 24 months, but there is a continuation of the separation of graft. So even at now, 6 years, what we see, there is a 67% overall survival versus 46%. So you have basically managed to change the way the graph looks now, okay? So you've given them a chemotherapy agent, you've given them anti-angiogenesis agent, now you have put them on an olaparib if they have a BRCA mutation. How about doing doublet therapy? So how about combining anti-angiogenesis and olaparib? This was very effectively looked at in the Paola trial, where the patients were randomized into olaparib and bevacizumab and compared to bevacizumab alone. Now this trial is criticized because it lacked a single arm of olaparib. So basically you're looking here as to what is the impact of olaparib on bevacizumab. If there's no arm which is looking at olaparib. And what we found is that if you have a BRCA mutation, you have a beautiful separation of the graph and you have a tail in this graph. Similarly, if you have a HRD mutation, excluding the patients who are not BRCA positive, still there is a benefit, whereas the benefit in the HRD negative is unknown. So by virtue of giving them different combinations, giving them double targeted therapy, you are able to have a long maintenance arm. How about, can you give PARP inhibitors in BRCA negative patients and patients who are HRD positive? So this was looked at in the PRIMA trial, which looked at all comers. So similar kind of patient population as the SOLO trial, but did not include, but was not exclusive, where it was all inclusive to all patients. And they randomized patients to a different PARP inhibitor, niraparib, and randomized it against placebo as a maintenance treatment. The difference was that olaparib is given once a day, and it was given for 3 years. And what you see is self-explanatory, that in patients who are HRD deficient, there is an improvement in the outcome in terms of the progression-free survival, and so is it in the HR proficient patient. So this was a little surprise, patients who are HR proficient, they are still benefit. Then they question whether the HRD testing that we use is inclusive, because there is a cutoff of 42 to include the patients who are HRD positive. So is there a cutoff beneath, lower than 42, which would also confer improvement? So the updated overall survival data of the PRIMA trial was presented, and it was found that although the progression-free survival is better in the patients who are HRD positive, there was no improvement in the overall survival. So we've done chemotherapy, anti-angiogenesis, we've done PARP inhibitors. How about doing triplet now? How about incorporating immunotherapy in a tumor, which is usually a very bland tumor? And so we add immunotherapy. We oncologists like to add things, and we are very excited when we see response rates. But then we have to be realistic as to what is the clinical meaning of that, how meaningful it is. So in this, what you do is you take a patient like a payola arm. So you have a patient, an arm which is just bevacizumab, you have an arm which is a payola-like arm, and then you add immunotherapy in that. And what you see is basically you improve the outcomes. You are going to improve the progression-free survival in patients, but there is a high rate of drop-off. There are added toxicities involved with it, and we don't know, we don't have biomarker analysis to see who are the patients who are going to benefit from this added targeted therapy. So to recap, a patient with ovarian CA on initial visit should have a germline panel testing done. All patients should have it. And this is the usual algorithm that we follow for all our patients. Patients who do not have bevacizumab, and if they are BRCA mutant, they are eligible for the SOLO-1 trial. If they are HRD deficient, then PRIMA, and give them niraparib. If they are HR proficient, then one can consider PARP inhibitor based on the prime time. If they had bevacizumab during chemotherapy and maintenance, and if you find that the BRCA mutant, you can put them on a payola-like arm and add olaparib. If they're HR proficient, you can continue them on the GOG 218 trial. So endometrial cancers has been made very easy for me by Dr. Bhagya Lakshmi. So quickly, we know that by characterizing these patients into 4 different groups, we are able to have a better prognostic indication. In the PROMISE algorithm, it uses both the IHC and the NGS. So to characterize the POL-E mutation, which is the good mutation, which is confers a good prognosis in the low-risk population, the low-stage population. So we try to use this in our molecular tumor board, where we look at this when a case is presented for adjuvant radiation therapy, especially in the early adjuvant setting. And what was done from the PORTEC 1 and PORTEC 2 trial, they looked at what was the added benefit of radiation therapy in these patients. So that they did a retrospective analysis of all the mutations from PORTEC 1 and PORTEC, and they found that in the POL-E mutant tumors, you can omit radiation. In the MRD, XRT has limited benefit, okay? In the P53 abnormal patients, nothing can be enough. Do everything that you can possibly. In the NSMP, BBT is the preferred treatment, and it is also stage specific. The PORTEC 3 trial, which looked at concurrent chemotherapy and radiation therapy, followed by more adjuvant therapy, they found again that there was no advantage of giving chemotherapy to the POL-E mutant. There is advantage in the P53 mutant patient. Probably these patients require PARP inhibitor as well. If you have an MRD patient, then maybe we don't know really. Maybe these are the patients who require adjuvant immunotherapy, and the NSMP trial are candidates for radiation plus hormonal therapy. And the RAINBOW trial was already mentioned. So just quickly, in the metastatic disease, we have game changers. Before, we used to give immunotherapy to patients in the second-line setting. Now we give it to the patients in the first-line setting. And we have 2 trials which have, to support that, we have the RUBY trial of dostarlimab, and then we have the NRG 018 trial of pembrolizumab. And both of them show that patients who have deficient MMR, they benefit more. And here there's actually a tail to the graph. That means that their patients are living longer, they are survivors here. And as well as there is benefit in the proficient arm. And the NGOT also showed there is a benefit in the overall survival with statistical significance. HER2 targeted therapy is something that can also be exploited to our advantage in gynecological cases. Anytime we have P53, IHC testing, MMRD, and POLE mutation, if you have the luxury of the POLE mutation, we always, most of the time, ask for HER2, because now we have the advantage of using antibody drug conjugates. So this trial is of Destiny Pan tumor trial. This is in patients who had different tumors, and what was found is by giving TDX3 antibody drug conjugate, where trastuzumab is bound to chemotherapy, there is an advantage even in patients who have endometrial CAs. So to conclude, germline and somatic testing should be offered to all patients with ovarian cancer, which influences the selection of maintenance therapy. Use the molecular classification for risk stratification and selection of adjuvant therapy to avoid overtreatment. Clear interpretation of the molecular test should be done, as was pointed out earlier, discussion with the pathologist. Integrated multidisciplinary approach should be made to optimize treatment and use the international guidelines. And above all, it should be a shared decision making where you should have a discussion with the family about the availability and the feasibility of these agents. Thank you very much.